Hello everyone and welcome. Today we're diving into a topic that's frankly a game changer for every single general practitioner out there, interceptive orthodontics. Now this isn't just for the specialists, this is all about understanding your critical role in spotting problems early and realizing you have the power to change a patient's entire future. And hey, if you're prepping for exams, you're in the right place because we are going to cover the must-know concepts. Let's jump in.
So take a look at this. This is some pretty severe crowding. We've all seen cases like this walk into our clinics, but it really makes you stop and think, doesn't it? Was this inevitable? Or could this patient's future have looked totally different if someone had just stepped in a few years earlier? That one question? Well, that's the whole reason we're here today. Here's our roadmap for today. We're going to start with the why and the when, that critical window of opportunity. Then we'll get into the science of facial growth that pretty much dictates all of our timing. After that, we'll build a systematic diagnostic blueprint, and we'll apply it to two of the biggest issues you'll see, managing space and correcting a patient's profile. And of course, we'll wrap it all up with the key take-home messages for your clinic.
Okay, let's kick things off with the most important idea. As general practitioners, we've all heard it. Maybe we've even said it ourselves. You know what? Let's just wait for all the permanent teeth to come in. Today, we are going to see exactly why, in so many cases, that can be the absolute worst advice you can give.
So what even is interceptive orthodontics? Look, it's not about waiting for a full-blown problem to show up and then fixing it. It's about being a detective. It's about seeing the small clues in a growing child, the little things that tell you a bigger problem is on the horizon, and stepping in right now to stop that problem in its tracks.
Now here's where we really have to get our priorities straight. Not all problems are created equal. If your patient has a skeletal issue, a problem with the actual jawbones, they shoot right to the top of the list. Why? Because there's a biological clock ticking. This is our window of opportunity. If you catch it while they're still growing, you can often guide that growth with a relatively simple appliance. But if you miss that window, that case can literally transform from a straightforward ortho treatment into a complex orthognathic surgery case as an adult. We're talking corrective jaw surgery. The stakes couldn't be higher.
So to know when to step in, you have to understand the blueprint of facial growth itself. It's not random. There's a predictable pattern, and that pattern becomes our clinical roadmap.
You know, what's really fascinating is that the face doesn't just stop growing all at once. It happens in a very specific order across 3 different dimensions. First to finish is the transverse dimension. That's the width of the upper jaw. Next up, the anterior-posterior plane. This affects the profile and the bite, and that keeps going through the mid-teens. And the very last thing to stop growing is the vertical dimension, or the height of the face. The take-home message here is huge. If you see a transverse problem, like a narrow palate, you have to treat it earliest. You just don't have the luxury of waiting.
Okay, that makes sense. Growth is our timetable. But how do we actually know where our patient is on that timetable? How do we take this textbook knowledge and apply it in the clinic on a Tuesday morning?
We use some really specific diagnostic tools. A lateral ceph X-ray lets us look at the cervical vertebrae, the bones in the neck, to see how much growth potential is left. For an even more detailed picture, we can use a hand-wrist X-ray. By looking at how the tiny bones in the hand and wrist are fusing, we can get an incredibly precise map of where a patient is in their growth spurt, and more importantly, how much more growing they have left to do.
All right, we've got the timing down. Now let's build our diagnostic blueprint. This is our step-by-step plan for every single evaluation. Remember, a great treatment plan is always built on the foundation of a solid, systematic diagnosis.
You can really think of this in 3 core parts. First up, the history. Medical, dental, and maybe most importantly, what is the patient's chief complaint? What's bothering them? Second, the clinical exam. We're looking at the patient outside the mouth, inside the mouth, and checking their function. And finally, diagnostic records. The essentials are always photos and study casts, and we can add supplemental records like specific X-rays when we need them. This system makes sure you never miss a thing.
So let's put this into practice. Our first big clinical challenge, managing space. This covers everything from a narrow upper jaw to severely crowded teeth.
Here's a textbook posterior crossbite. You see how the upper teeth are fitting inside the lower teeth? This is a massive red flag for an underlying skeletal problem, a maxilla that is just too narrow. And what did we learn about our growth timeline? This is a transverse problem, which means it is priority number 1 for early treatment.
And here is the why behind it all. The 2 halves of the maxilla, they're joined by something called the mid-palatal suture. In a young patient,
This suture isn't fused together yet. We can gently separate it, stimulate new bone to grow, and widen the whole arch. It's a really stable physiologic process. But if we wait until after adolescence, that suture fuses solid. Now, trying to widen the arch is way harder and much less ideal. Early intervention is literally everything here.
So how do we do it? We use an appliance called a maxillary expander. It applies this gentle lateral pressure, and you can see it right here in this X-ray. Look at that. It's physically separating the two halves of the palate, right at the suture, creating the space we need for a wider, healthier arch.
Now, what about cases with just severe crowding, not necessarily a width problem? We have another powerful interceptive tool called serial extraction. And this has to be a very, very carefully planned procedure. It involves strategically removing certain baby teeth and later on, specific permanent teeth in a really precise sequence. The whole goal is to create space to allow the other erupting permanent teeth to guide themselves into a much better spot, which can dramatically reduce the final amount of crowding.
Okay, so we've covered the width of the jaw. Now let's shift gears and look at the front-to-back dimension, the antero-posterior plane. This is what really defines a patient's profile.
On the left, you can see a Class 2 malocclusion. This is often because the lower jaw just hasn't grown forward enough. And on the right, we've got a Class 3, where the lower jaw is often too far forward. Both of these are fundamentally skeletal problems that we really want to influence during that precious growth spurt. So with all these different appliances and options, how in the world do you decide what to do? Well, this is where a decision-making map, a flowchart like this one, is incredibly useful. It helps us connect our specific diagnosis to the right type of orthopedic appliance. It might look a little complex at first, but it's super logical. Let's just walk through an example together.
Okay, so let's imagine we have a Class 2 patient. Our diagnosis shows us that the problem is a deficient mandible. The lower jaw is too small. So we find that on the chart. Now just follow the arrow, and boom, it leads us directly to the category of functional appliances. These are things like a twin block or a frenal 2, and they're designed specifically to encourage the mandible to grow forward and catch up. You can see how this kind of system just takes all the guesswork out of treatment planning.
So, after all of that, what are the big things you absolutely need to remember when you walk into your clinic tomorrow morning? Let's boil it all down.
First, timing is everything. Just burn that order of growth cessation into your brain. Transverse, then AP, then vertical. Second, skeletal problems are always a high priority. Don't wait on them. Third, a systematic diagnosis is not optional. Fourth, know your limits. Know when you can treat and when it's time to refer. And finally, never, ever forget your power. As a GP or a pediatric dentist, you are the gatekeeper. You are often the very first person who can spot these issues and literally change a child's life.
I really want to leave you with this one last thought. The single most dangerous piece of advice in these situations can be, let's just wait and see. Your job, your responsibility, is to have the knowledge to know exactly when not to wait. Thanks so much for tuning in.